be used for inhalation rather than exhalation, and it gets easier for them. So it decreases their workload of breathing. In pneumonia, signs can be, airway, respiratory distress, use of accessory muscles. You may find fever, cough, really creamy, yucky looking sputum, wheezing, agitation, cyanosis. So it may look very similar to CHF, but if they don't have a history of CHF and AFib, and they have this productive cough and fever, it may be more of pneumonia than heart failure. So it can be confused with CHF, especially because you don't have an X-ray right there on the truck to sort of see a consolidated right lower lobe. CPAP has been used in pneumonia in the past, but it may be not so beneficial. And the reason why is because if you have a consolidated lung, even though you push air in there, you still have all this really thick, gunky mucus, and that's not allowing for the good gas exchange that you need. So even if you're trying to stent the airway open, you still have all that gunk in there that's not out yet. After antibiotics and nebs and all that and mobilizing that, then they end up getting better. Other uses of CPAP, they talk about drowning. I think it's not unreasonable actually to use it in drowning. That I think got a lot of support in the literature, or at least they're really starting to talk about it, I think, a bit more. ARDS, acute respiratory failure, atelectasis, left ventricular failure, sleep apnea, big one. It's used a lot, obviously, with sleep apnea. Renal failure, there's papers coming out this past 5 years saying that chronic kidney disease is related to CPAP, and if you treat their sleep apnea, related to sleep apnea, if you treat their sleep apnea with CPAP, it actually improves their kidney function. I've been seeing actually a fair amount of referrals from the Portsmouth group for patients who have chronic kidney disease, and trying to buy time before they need to go on dialysis, or hopefully prevent dialysis. It's definitely used as a weaning mechanism from the ventilator, and it can be an alternative to mechanical ventilation. So monitoring response to CPAP, what do you look for? You look for a reduction in the respiratory rate. It's not 28 anymore, now it's 18 or 20. Improved heart rate, decrease in blood pressure, increased oxygenation. End-tidal CO2, if you're monitoring that, you may actually see an increase and then eventually a decrease. Subjective dyspnea score, the Borg scale or the visual analog score. I don't know if you use the modified Borg scale, but I put it up there for 0 it being no breathlessness at all, and then 10 being maximum. So what are the bad things can happen? If you put somebody on CPAP, their anxiety can sort of go high because they can't handle something on the face, and that's a big one. So in the literature, they say, try to talk them through it. You tell them that it's just going to help you. A little bit of morphine can help sometimes, a smidge of that to sort of calm things down and really be able to tolerate it on the face. If hypotension develops, bad thing, don't want to be using CPAP with hypotension, pneumothorax. If the belly starts blowing up, you might want to stop it, vomiting or worsening respiratory distress. Okay, I think I'm just about done. I think that took it's less than an hour. So pre-hospital, I just wanted to end on this. It actually doesn't have a whole heck of a lot to do about CPAP, but pre-hospital use, this came out in 2011, about a year ago, of oxygen in COPD patients. So they looked at 250 patients with an acute exacerbation of COPD. 77, 31% died. They required mechanical ventilation or they were in respiratory failure. And they showed that there was the increased O2 flow rates given to them was associated with a higher risk of death, as was assisted ventilation or respiratory failure. In 405 patients with an acute exacerbation of COPD, if the oxygen was titrated, mortality was reduced. 21 deaths versus 7 deaths. Hypercapnia was better. Respiratory acidosis was better compared to those high flow oxygens that is often given. So there's probably going to be more on this if you don't already know, more on this. But I just remember that when I was a resident, it was not uncommon that I would be called to a code and the patient was put on oxygen and they were on 2 liters, 3 liters, 4 liters, something like that. And they were talking and then all of a sudden they just sort of went like this and they crumped. And the reason why is because when you have underlying lung disease, normal lungs function on very minute changes of carbon dioxide. So you have in your carotid arteries, you have baroreceptors that sense your changes in carbon dioxide. And it tells your brain to tell your lungs to breathe or not breathe, right? So what happens is that when you have underlying lung disease, your carbon dioxide levels drift up because you can't exchange gases very well. So you now reset your CO2 levels. So normal CO2 levels are 40 to 45 millimeters of mercury. So now you're resetting to 50 or 55 or 60 or 65. And so what happens is that you lose that very exquisite control of breathing. And instead of functioning on your CO2 levels, you now function on your O2 levels. And O2 levels are just clumsy, because a little bit of O2 going up or a little bit of O2 going down tells your brain to breathe or not breathe, and it doesn't really work very well. So then you put somebody on oxygen because their SAT's 91%, so we got to put them on oxygen. And now they fall asleep on you because now they have hypercapnia. And their CO2, if you did an ABG and their CO2 level is now 95. And the reason why is because you've just so overloaded their O2 drive to breathe. You've made their CO2 levels just go sky high and now they're intubated. So the point of this last slide is that you sort of have to watch. I tell my chronic lung patients to buy one of those $50 O2 oximeters from Walgreens and know what their oxygen is at home. Medicare doesn't allow me to prescribe oxygen unless your oxygen levels are 88% or less. So if you're a chronic lung patient, you should be shooting for 90 to 93 in terms of an O2 sat. Normal O2 sats, 9,500%. 9,500%, everybody in here has got normal O2 sats. But when you're a chronic lung patient, you have to tolerate slightly lower levels. So if somebody is huffing and puffing and they have a CO2 exacerbation, and I saw one in my office just the other day, his SAT was like 91%, we gave him a neb, it came up to 93. I didn't put oxygen on this guy. I just gave him a neb, it came up to 93, I gave him his prednisone, I gave him his antibiotics, and hopefully kept him out of the ED. But you got to watch that. Don't put them on the oxygen because then they'll could fall asleep on you. Now, why do I say all this? CPAP can help. CPAP can really help oxygenation. And you don't have to crank up the oxygen all the way. Once you put, it is not uncommon, very, very common, that I have patients who have bad sleep apnea and they have severe sleep apnea and they have an hour throughout the entire night that their oxygen levels are low. And I put CPAP on them at nighttime and their oxygen levels are nice and normal at 94% all night long. I don't have to add oxygen in. I don't give them any extra oxygen. All I'm doing is stenting their airways open a little bit so they have better oxygenation and ventilation. So I don't have to give any extra oxygen. But on that study, that original study that they had, they went down to 67%. They went up and down sort of all night long. But now I give them a little pressure and their oxygenation is 94% all night long. So my point is, when you give the CPAP for a chronic lung patient, a COPDer, you may not need to crank that oxygen way up. Just watch, watch it and be careful. I would say don't go above 95%, but I don't know what your protocols are. But maybe to avoid that intubation. But there may be more literature coming out in this in the years to come, because now CPAP is on the trucks. And I think that's it. So questions? Yeah.
Yeah, on that last slide.
Yep.
We used to be told in a COPD patient, don't give them non-rebreathers, give them nasal cannula, 2 liters, don't overdo it with oxygen.
Right.
And then
Now,
5 years ago, new protocols came out, they said, don't withhold oxygen, give them full non-rebreather. So now I think your suggestion maybe go back the other way.
well, I think I'm not as hip maybe on the EMS literature as you guys probably are, but I came across these articles saying, oh, well, maybe we should be looking at this a little bit more. In general, if somebody needs oxygen, you don't withhold it. You know what I mean? They're crashing and burning. You put the oxygen on, you get a tube in them. You know what I mean? Like it's sort of a no-brainer. But the no-brainer part is the patient really that bad to need all that oxygen and the tube? That's the bad part. So when I was called for a code in the hospital, can I put CPAP on this guy and get him out of what he is in right now and not have to put a tube in him? I mean, I think you guys ask the same questions in the field. So I don't know how to answer it. I mean, sometimes you can see them through their bad moment and sometimes you can't. It depends on that clinical scenario. But I think I would personally not throw the non-rebreather on them. I would, depending on the situation, especially if they're a COPD or if they're in pulmonary edema, I'd put CPAP on them and then just sort of watch them, see how they do.
So would you say that most COPD patients currently probably have a CPAP machine at home?
No. Most COPD patients do not have a CPAP machine at home. There's this thing called overlap syndrome, and 20% of patients who have COPD have sleep apnea as well, around that, somewhere around there. And those patients have their CPAP machines at home, they got their nebs, they got everything at home. I would say most COPD patients do not have CPAP at home. Not only that, but I would almost say that a lot, I don't know about most, but a lot of COPD patients don't even want to be told that they need oxygen. And when they come in to see me, I'm usually trying to gently hold their hand through the idea of needing oxygen.
So if we go to a patient, COPD patient, and they're tripoding, cursing the lips, the whole 9 yards.
Right.
And we ask them, do you have a CPAP machine? And they say yes.
Put it on.
Put it on and bring it with us to the ED?
Yeah, unless, I mean, you could do the same thing with your OxyPeep. You could put that on 5 to 10. And I probably wouldn't go a whole heck of a lot higher than 10. And the reason why is because when we auto-peep, normally without any external devices, it's about 5 millimeters of mercury. So normal auto-peep in a person is about 5 millimeters of mercury. So I would do 5 to 10 and see if just holding their airways open allows their work of breathing to be less in that time period of taking them to the ED. I don't know that I would necessarily use their machine at home, and the reason why is because the physiology of breathing during the day is not the same as the physiology of breathing at night. And that's a whole lecture in itself, by the way. I mean, like, just, it's different.
Is there math in
No, but I could make it with math. I'm sure I could.